Good afternoon and welcome to our series of webinars focused on bringing you information about COVID-19 related topics. The information in these weekly webinars is geared toward long-term care and skilled nursing facilities, but we encourage everyone who is interested to attend. My name is Kathy Caudill. I'm a communications specialist with Quality Insights. Today's webinar is Candida Auris, Calm, Not Chaos. Everyone has entered the meeting on mute, but we will have a Q&A following the presentation. If you have questions or comments, please submit them using either the chat or the Q&A tool in your Zoom menu. We invite you to join us every Wednesday for more of our weekly webinars. Next week's webinar will be a replay session of our recent presentation on increasing infection prevention with interactive education, followed by a live Q&A. If you're interested in joining, that will be the same time and place next Wednesday at 2 p.m. And now I'd like to introduce our guest today, Valerie Jividen. Valerie is an epidemiologist and the lab-epi liaison for the West Virginia Department of Health, Bureau for Public Health in the Office of Epidemiology and Prevention Services. Her passion for infection prevention began 30 years ago when she earned her ADN from the University of Charleston. Being a lifelong learner, she later earned her BSN, followed by an MSN and a Master of Science in Healthcare Administration. She is West Virginia's MDRO program as part of the HAIAR team. And when not at work, she enjoys spending time with her family and miniature dachshunds, Helga and Ava. Valerie, thank you for joining us today.
Thank you. And thanks, everybody. Good afternoon. I'm so happy to be here spending a little bit of time with you. We're going to talk today about Candida auris, as she just said in the introduction, and I anticipate you probably will have some questions. So at the end, I would like to take time to talk it over. If you think of anything, please don't hesitate, and you don't have to wait till the end. If you want to chat during the presentation, that's fine, and we can talk about it. So Candida auris, calm, not chaos. The reason we went with this title for this presentation is because although C. auris is a serious health threat to people that have chronic conditions, comorbidities, and anyone who's immunocompromised, it is manageable if the right steps are taken to prevent its spread. We'll talk more about that in just a few slides. But today, my goal is to provide some evidence-based information that after you hear the presentation, you may be able to confidently care for patients or residents who are colonized or have active infection with C. auris. These are our objectives. We're going to review Candida auris, or you'll hear me call it C. auris. That's the more commonly used name for this infection. We'll talk about the definition and the background, review some of the roles and responsibilities of different entities that are involved in a follow-up investigation after a positive lab report. We will go over some frequently asked questions, and then we'll apply that new knowledge to talk through. I have about 3 case studies that we can talk about. So, multi-drug resistant organisms, referred to as MDROs, is an umbrella term you see here in this illustration, and it's used to describe organisms that resist antimicrobial treatment. So there are several additional acronyms to name some of these specific organisms. You see there we have methicillin-resistant Staphylococcus aureus, or MRSA, which is very common. Carbapenem-resistant Acinetobacter baumannii, or crab. It's a bacterial infection that may sound familiar to most of you. And then we have C. diff, and that's just to name a few. Let's talk about some background. So Candida auris is a type of yeast that causes fungal infection in or on various parts of the body. It can colonize the skin and be easily spread from person to person. Containing spread is primarily dependent on quick detection and implementation of appropriate infection prevention and control practices. So whenever we are notified of a positive CRS, we right away start the investigation so that we can hopefully prevent it from moving to other patients. So why is CRS such a problem? Well, it can cause infection in wounds, in the bloodstream, or pretty much any other area of the body. Patients who are either hospitalized or in nursing homes, or anyone who has multiple medical problems, are particularly at risk for getting CRS. Patients also have a greater chance of dying within 1 month of diagnosis. So I'm not sure what that percentage worked out to, but once you have active Candida auris infection on top of all multiple other problems, then those patients don't do well. It's often resistant to all three of the major classes of antifungal medications that are available. Those are fluconazole, or also known as diflucan, amphotericin B. When I worked in the hospital, that was what we called a big gun antifungal medication. And then the third one that CRS is usually resistant to is micafungin or micamine. And so as a result, that leaves precious few, if any, medications that are left to treat Candida auris. It's become more common. It was first discovered in Japan back in 2009, where it was isolated from a patient's ear. The word auris is Latin for ear, and thus the reason for that name. Since then, outbreaks have emerged around the world. The first cases here in the United States occurred beginning in May 2013, so it's been nearly 11 years ago right at this point. The first cases in West Virginia happened just last year, and some of you may have heard about that. There were 4 cases total in West Virginia in 2023, and so far this year, we've had 6 CRS infections. That doesn't count the people who are colonized. When I say CRS infection, those people are known as the index patients. But we fully expect this number to continue to increase, unfortunately. CRS is very difficult to treat. It is often misidentified as Candida how did I say it, Emily? Humuloni. There, excuse me. That's also another a rare yeast infection. But misidentification of these labs depends on the lab methodology that's used. It takes specialized equipment that's needed to properly isolate the organism. As I pointed out earlier in the slides, it is easily spread, and it will survive for weeks, if not months, on surfaces of healthcare facilities. It was added to the Center for Disease Control's Urgent Threats Report from 2019 also. So shockingly, there was a 318% increase in cases during 2021. And so data since then is being analyzed for each year subsequent to that. So you can see there are several reasons why we need to definitely address Candida auris in our healthcare communities. This map is quite interesting. It illustrates the number of cases in each state for the year 2022. If you see the bright orange colors, you see California, Texas, Nevada, Florida, some of those larger states. That color indicates that there were between 501 and 1,000 cases of CRS in 2022. The slightly lighter orange color, that would include Arizona, Georgia, Pennsylvania, Virginia, Kentucky. Most of the states short of Ohio in 2022 had between 51 and 100 cases of Candida auris in 2022. So the reason that's important is, you may already have guessed, we have a lot of West Virginia residents who will cross the border to either Ohio, Kentucky, Pennsylvania, Virginia to seek health care. And then likewise, we do have some residents who are not West Virginians who come into hospitals in West Virginia for treatment. So that leaves us susceptible and always on the lookout for new colonized patients or actively infected. If you want to learn more about this map or to see real-time information, that web address is there at the bottom of this slide, and you'll have a copy of it when you get a copy of the slides. So the first case of Candida auris we found February 23rd, 2023, and that just happened to be in the northeastern surveillance region. For right now, West Virginia is broken up into 6 surveillance regions. And luckily, that first case, we did not find any additional patients who were colonized as a result of being in contact with that index patient. So we were happy about that. There were 2 additional clinical cases identified in March of that year. These 2 were in the western region, and then another one was identified later that year on December 6th with Candida auris. And you can see there, when we do have active infection, we take a look at the situation and decide, do we need to do lots of screening, or are there an isolated number of patients that should be screened? And so that's important to keep in mind when you are beginning an investigation here. And so we have had a total of 10 actively infected patients up until today so far in West Virginia. This is a copy of the Candida auris HON alert or health advisory notice that was sent out by our state epidemiologist, Shannon McBee. And this went out in March last year. It's small. I know you can't read it, but again, you will have a copy of this in the slides when you get those. Here are a couple of web pages that you can go to get more information. CDC, and then the one below that is our OEPS wv.gov webpage that you can go to as well. Let's talk about transmission of Candida auris. So a person can have C. auris living on their skin without even knowing it. So let's look at an example. So you have a person that might be colonized with Candida auris. Anyone who is colonized and otherwise healthy can spread that from to other people and onto objects, which are known as fomites. So it can live just like those C. diff spores. They can live on surfaces for a long time, and you can't see it. So it's important to do those hand hygiene audits and that sort of thing. So C. auris is quite difficult to get rid of without meticulous and frequent cleaning using products that are confirmed to be effective against C. auris. So in this example, Mrs. Brown is in room 100, and she is a patient with active C. auris infection in a wound. She is being assisted with bathing by a nursing assistant, Jane. After Mrs. Brown's bath and a change of her bed linens, Jane bundles up the dirty linens and goes to the dirty utility room to drop them off. As she exits that utility room, she sees that the milk cart has just arrived on the unit. So she immediately starts to pass trays since there are so many patients on the unit, and she doesn't want that food to get cold. You might be able to, in this example, point out the opportunities that Jane missed in this routine. I would like to think and would imagine you would say hand hygiene and the use of appropriate PPE is definitely high on the list of things that Jane should have done better. 3 days later, the infection preventionist at this facility conducts screening for C. auris of other patients who may have been exposed, and those people are known as contacts. Mr. Brown, who's in room 101, who was admitted for a bowel obstruction and surgical intervention, and then you have Mr. Green in room 105, who was admitted for pneumonia that is getting better. But both of these patients learn that they have screened positive for having C. auris colonization of the skin. So, after an investigation, the infection preventionist discovered that Jane had cared for all 3 of these patients for the last 3 days. And after a discussion, Jane admitted that she was in a hurry and didn't think about wearing a gown or gloves to bathe Mrs. Brown, and that she could do better with washing her hands. So it was a teaching moment. Mr. Brown began to have signs and symptoms of active infection. He had a fever of 102, and his wound became red and hot to touch. His physician ordered a wound culture that revealed that he indeed had an active C. auris infection. A week later, Mr. Brown expired. In this scenario, it could have played out a whole lot different if just a few simple steps could have been taken, especially on Jane's part. And this was inspired by true events. So it's a serious matter, but it is also a manageable thing to deal with in your facilities. People who get invasive Candida infections are often already sick from other medical conditions. So it can be difficult to know if it is in fact a C. auris infection. The most common symptoms are fever and chills that don't improve after they've had antimicrobial treatment for a suspected bacterial infection. C. auris can infect different parts of the body. Symptoms depend on where that infection is, as well as the severity of the illness. It can colonize or infect people of all ages, from preterm infants to the elderly. People who are colonized, meaning those without signs or symptoms of infection, can still transmit C. auris onto surfaces and objects. So I've repeated that several times throughout the presentation, and it's one of those points that cannot be stressed enough. Risk factors. C. auris mostly affects patients with severe underlying medical conditions and requiring complex medical care. Patients who have invasive medical devices like breathing tubes, feeding tubes, catheters, vascular access devices, or urinary catheters tend to be at increased risk for getting C. auris and for eventually developing an infection. People who are colonized with other MDROs and those who have received antibiotic and antifungal treatments in the past are at increased risk. Anyone who has received care in a ventilator-equipped skilled nursing facility or a long-term acute care hospital are also at increased risk as well. Cleaning physically removes most germs, dirt, and impurities from objects and surfaces, but disinfecting kills any remaining germs. Killing germs can further lower the risk of spreading disease. So if you're part of environmental services or you work with people in that department, it's important that they receive education and understand how important it is to terminally clean these patients' rooms and make sure that they are doing all of the steps they're taught to do, from clean to dirty, and the same education you would use if you were to treat a C. diff patient. And we are happy to help out with education too, just as Quality Insights has Project First Line Education. We would love to help you with that. So The CDC recommends that you use an Environmental Protection Agency's registered hospital-grade disinfectant that is proven to be effective against C. auris. If you go online and you check out the EPA's website, you'll look for List P, as in Paul, and that's where you can see the most current list of products that you can use for C. auris. If the products on List P are not accessible in your facility or otherwise suitable, then you may use an EPA-registered hospital-grade disinfectant that works against C. diff spores, which is called List K. Regardless of the product selected, it's important to follow all manufacturers' directions for use, including applying the product for the correct amount of contact time, or you may hear it called kill time or wet time. But the surface needs to remain wet for whatever amount of time that is according to the manufacturer. Research about disinfection effective against C. auris is ongoing. There's still a lot that we don't understand and know yet about it. Data on no-touch devices, that would include your germicidal UV irradiation or the vaporized hydrogen peroxide machines. The research on those are limited, and the parameters required for effective disinfection are not yet well understood. If these methods are used, they should be used only as a supplement to standard cleaning and disinfection methods. Another point I can't stress enough is you do need to follow all manufacturers' directions. Some products with Candida albicans or fungicidal claims may not be effective against C. auris. So even though it's Candida albicans, you would think Candida auris it would be effective. It is not. And there is accumulating data that indicate that products solely dependent on quaternary ammonia compounds, or QACs, are not effective. C. auris has been cultured from multiple locations in patient rooms, and this includes surfaces such as bedside tables, bed rails, surfaces that you don't necessarily think the patient would touch, but could be as far away as the window sills or even outside the entrance door. So all of those areas need to be meticulously cleaned and disinfected. Reusable or shared equipment also should be put on a cleaning schedule. That includes your glucometers, your temperature probes, blood pressure cuffs, ultrasound machines, nursing carts, and crash carts. Transmission-based precautions, and let's talk about patient or resident placement. So number one, frequent and thorough hand hygiene is required. Healthcare personnel, or HCP, as you'll see abbreviated in this presentation, should use contact precautions to manage patients with C. auris in acute care hospitals and LTACs, the long-term acute care hospitals. Residents in nursing homes or who reside in skilled nursing facilities should use either contact precautions or, now that CMS has made it mandatory as of last week, enhanced barrier precautions. Are there any questions about anything so far?
No, there are no questions so far, but if
Okay.
anyone does have a question, you can raise your hand if you would like to ask a question at this moment.
All right.
All right.
So when single rooms aren't available, then that's when facilities may choose to cohort patients with other Candida auris positive patients in the same room. While it is preferable to cohort patients that have the same MDRO, facilities may assign rooms based on single or a limited number of high concern MDROs. For example, C. auris or any one of many carbapenemase producing enterobacterales. without regard to co-colonizing organisms. Does that make sense? If it doesn't, speak up. So facilities can place patients with CRS together in a dedicated unit or part of a unit to decrease movement of healthcare personnel and equipment back and forth between patients. Facilities could also consider dedicating healthcare personnel who provide regular care to these patients during a shift. And I know that's not always feasible, but that is also an option for you if you are having trouble. When patients are placed in shared rooms, facilities must implement strategies to help minimize that transmission between roommates. So those include, regardless of people are colonized or infected, to maintain separation of at least 3 feet between beds, use that privacy curtain in between the patients to limit direct contact. And as we talked about, clean and disinfect as if each area or bed area were a different room. For example, you would clean and disinfect any shared or reusable equipment between patients. Housekeeping or environmental services would need to change mop heads, cleaning cloths, and other cleaning equipment between bed areas. And then you would want to clean and disinfect environmental surfaces on a more frequent schedule. And then healthcare personnel should change PPE if worn or if that is required for the situation, including gloves, and perform hand hygiene before and after interaction with either roommate. So you would just imagine that curtain in between is a wall, and treat each one as if they're in their own separate area as far as donning and doffing PPE. Duration of precautions and decolonization. Contact or enhanced barrier precautions are recommended for the entire duration of all inpatient or residential healthcare stays. This includes long-term healthcare settings. And so I'm pretty sure one of the frequently asked questions we'll talk about is, so do I need to be in precautions from, for infinity? And at this point in time, yes. Anytime that you have been infected or colonized with an MDRO, particularly Candida auris, then you would be considered permanently, indefinitely colonized. There's a lot of research going on in this area, but for the moment, we don't have specific interventions. CRS is a Category 1 emerging infectious disease in West Virginia, meaning it has never or rarely occurred here, making it reportable by laboratories or healthcare facilities to your local health departments within 24 hours. And then, so there's criteria that you would follow if you do need to report. You should have detection of CRS in a specimen using either culture or a validated culture independent test like the nucleic acid amplification test. Or if you have a report that shows detection of CRS from any body site using either culture or a culture independent diagnostic test like PCR or polymerase chain reaction. And then the third and final way is detection of C. hymelloni from any body site using a yeast identification method that is not able to detect CRS. So like we were talking about before, that C. hymelloni is often what labs will call a true Candida auris infection because it misdiagnosed it as the hymelloni. So if you see that, you would want your lab people to give that some consideration and get it confirmed that it is in fact or is not CRS. The most reliable way to identify it is through the matrix-assisted laser desorption or ionization time of flight mass spectrometry, and that's a mouthful, but you may have heard it called MALDI-TOF MS, and that is the #1 way to detect it accurately. We've mentioned screening a few times throughout this presentation. So what is it? It is routine testing of patients who do not have symptoms, are asymptomatic, but who may have had close contact with patients that are newly identified as having C. auris infection or colonization. So screening should be considered for any patient who is at high risk. And some of that criteria includes close healthcare contacts of patients newly identified. That would include roommates and patients or residents who shared a bathroom with the initially infected patient, and that person's known as the index patient. Also, patients or residents who are currently admitted to the rooms where that index patient stayed at least one night. So that situation may be, say, Mr. White leaves room 100 and 14 hours later, a new patient is admitted to that room. Ideally, that room would have been terminally cleaned and disinfected, but this also would want to be someone you would consider screening, just to be on the safe side. Patients who have had an overnight stay in a healthcare facility outside the United States in the previous 1 year would also be someone that you would screen, particularly if they were in a country where C. auris cases are documented and is an endemic to that location. Health departments and healthcare facilities should strongly consider performing more extensive screening, such as point prevalence survey, if there is evidence or suspicion of ongoing transmission in a facility. An example of that might be if you've detected it for multiple patients through contact screening or clinical cultures, or if there's an increase in infections from unidentified Candida species. In a point prevalence survey, or you heard me call it a PPS, every patient on a given unit or floor where the transmission is suspected should be screened. Early last year, we had a couple of acute care hospitals who did choose to track down patients who had potentially been in contact with that patient, but had since been discharged to home or other facilities. Communication is a big part of C. auris, and another reason why I'm glad I got to do this presentation with you guys today, because talking about it and being aware is so, so important. So if you have a patient that has been identified, you want to make sure you review your facts about C. auris so that you can be more confident when you go in to talk to patients or their families. Use plain language. You want to frame the screening as painless and it is beneficial. We'll look at what makes up a screening test kit, but it's not invasive. You use the swab to screen or to swab in the groin and axilla areas, and it doesn't hurt at all. Consider healthcare staff comfort when you discuss this. So make sure it's in a private area. You don't want to embarrass anybody. So keep that confidential. And then we do have actually CDC provides scripts that you can follow if you're more comfortable with that gives you tips on how to speak to patients and families. And that's easy. You can go to the CDC website and just Google talking points for C. auris patients. And there are templates that you can adapt to your own facility. So, like I said earlier, this is what you would see in a colonization screening kit. You have your biohazard bag, which has a main compartment and then an outside pocket. You have there, you see on the right is a sterile swab, a parafilm square, an absorbent pad, and then the paper that's folded up is specimen collection instructions. And that shows you exactly step by step how to collect that swab. Before you package it to ship it anywhere, whether it be our Mid-Atlantic Regional Lab or the state lab, you make sure you put the requisition form in the outside pocket, and it shouldn't be inside the main pocket with the specimen, just in case it leaks or comes open in transit. In that situation, labs will usually discontinue that test and it has to be done over. This is a copy of that instruction form I was talking about, and I know it is tiny, but again, you'll have it in your slides. But it's called an e-swab, and then it shows 1, 2 under the arms, 3, 4 in the axilla. You would take the cap off the swab collection tube. You use that swab to rub over all 4 areas, and then you insert that swab back into the tube. You wrap the cap on the tube with the parafilm to keep it, reduce the risk of it coming loose, and then you put it in the inside of the bag and ship it off to your lab. All of those, and this one has come up many times before, but the swab itself needs to be labeled with the patient name, the date of birth, and the collection date as minimum information you want on there. Sometimes tubes are not labeled, and those automatically are rejected at the lab, regardless of whether they are accompanied by a lab requisition. They both have to match up. Patient identifiers must match the accompanying requisition. Don't place that requisition, like I said, in the main compartment. Colonization screening requires generation of requisitions. So if we are using the Mid-Atlantic Regional Lab, then myself or Emily here in our MDRO team will print those requisitions for you and make it as simple as we can to facilitate. I know it's difficult to have extra time to do anything, but we want to be there to help you through it and make it as streamlined as possible. Candida auris specimens should be kept at room temperature, and they need to be tested within 5 days of collection. And then there are specific ways that these need to be packaged up for shipment. And your whatever lab you work with can help you with that. Okay, some of the roles and responsibilities. So providers should, as soon as they are made aware of a positive CRS result, should immediately notify their local health department. They should also ensure that lab reporting is being provided directly to providers. If you have a person, probably the people that are in this audience today, this wouldn't apply to, but if there's an office staff person who receives phone calls and are notified of positive culture results, then they need to have in their processes to immediately identify or notify the providers. The infection preventionist at the facility where the patient is hospitalized should be notified by the provider. And MDRO CRS status should be communicated to patients. Ideally, the provider will give that information to the patient before they are transferred or admitted to another facility or unit. So it's of the utmost of importance to make sure this happens quickly. So what does the lab need to do? They should report the C. auris infections immediately or colonizations to healthcare facilities. This needs to happen within 24 hours. Again, they should follow CDC and clinical lab standards, institute for testing, and then they should retain those Candida auris positive isolates for shipment to the Maryland lab. They are able to, at this time, perform whole genome sequencing, and that just gives us more information as to which of the 5 clades of C. auris are we dealing with when we have a positive case. The local health department will enter information and details about the investigation in our system called the West Virginia Electronic Disease Surveillance System, or EDS. That's what it's known as. Quick action to start an investigation reduces the risk that that MDRO will spread. Information should be obtained by contacting by phone, and this is what the local health department will do. We'll reach out by phone to the provider, to facilities, your infection preventionist or directors of nursing in your long-term care facilities, and they'll ask questions about which room was the patient in, did they have roommates, and we'll ask those sorts of questions in order to complete an investigation. Continued, the local health department has a lot to do when they're investigating those cases. They will assess long-term facilities knowledge using an initial assessment for healthcare facility with reported case of Candida auris. I'm sure most of you have experienced what's called an ICAR, and that's what we're talking about. Whenever there is a case of C. auris, then you're going to have a visit from the ICAR team here in our office. They will go through and provide a fresh look, outside eyes, and potentially identify gaps or opportunities to do better as far as infection control and prevention. The state health department, and that is our role here. Once that investigation is completed by you and the local health department, the regional epidemiologist will then forward that on to me or Emily on my team. And then we have up to a week to verify and close those cases. So you'll also sometimes get calls from us as part of an investigation. So now let's go over some frequently asked questions. And one that I've gotten several times is, if this is so easily spread from person to person, then why aren't we screening healthcare personnel? So healthcare personnel only rarely become infected with C. auris. Some can be infected, but should not transmit it to patients if they are following recommended infection control practices, including that hand hygiene and use of gowns and gloves. Colonized staff in long-term care facilities, if they do know that they are colonized, then they should comply with the recommended enhanced barrier precautions. Staff in other healthcare settings should also comply with contact precautions. And also healthcare personnel, if you're otherwise healthy and have no infections or any cold, flu, anything like that going on, then your risk of becoming sick is very, very minimal. Should we screen patients to document clearance of C. auris? I alluded to that answer in the presentation, but the answer is no. It's generally not recommended that you rescreen for clearance. There isn't enough evidence yet to support that. Many patients or residents remain colonized over months or years, especially if their medical status remains the same. Screening resources are limited, so you do need to prioritize those at higher risk and start with those patients and then work your way down to those who may not have been as high risk. Colonization can be intermittent. One negative screen does not indicate that they have been cleared. Next question. Do we need to place someone on contact precautions or EBP while awaiting admission screening results? In the events that we've had so far in West Virginia, that's been the number one question. Do we keep these people in isolation until they get their results back, which can take about a week and a half to know? So the answer to that is if someone is transferred from a facility with a known exposure, then you need to try to place that person in a private room on contact precautions or EBP, depending on the facility type. And I think most people on today are nursing homes and long-term care facilities, so EBP is what you would want to do. Are there false positives or false negatives with these tests? And yes, all tests have some degree of false positives and false negatives, but facilities and labs work together to keep these false results to a minimum. Facilities can also help avoid negatives by making sure that there is enough material on the swab when they colonize those patients or screen for colonization, and make sure that all collecting instructions are followed as instructed. And so facilities can avoid false positive results by making sure you keep that swab sterile and using sterile technique while you're collecting the specimens. You don't want to take the swab out of the tube, lay it down on the patient's blanket, and then use it to swab. You don't want that to happen. Any questions? Okay. So now let's take a little bit of time to go through some case studies. So listen carefully. We have case study number 1. So this patient is an 81-year-old man. He is a resident on a ventilator unit in an LTAC, and he has been there for 3 months. He has a urine culture that confirms C. auris and also a carbapenem-resistant Klebsiella pneumoniae that's positive for New Delhi metallo-beta-lactamase carbapenemase enzyme production, or NDM. So this is the first case of C. auris that's been detected in this facility, and it is uncommon in that region. He had not been on contact precautions or EBP, but he is now in a private room on EBP. He had 3 roommates prior to changing rooms, and there are 20 additional residents located on that same unit. So, question 1. What type of colonization screening will the health department most likely recommend to be done initially? Would it be A, response-based PPS for C. auris, but limited to only roommates and people in rooms adjacent to the index patient, which is known as targeted screening? Or B, response-based PPS for C. auris with screening all residents on that unit? C, proactive point prevalence survey? Or D, would it be discharge screening? Anybody want to take a guess? You can type it in the chat if you like. Any guesses? All right. Oops. The answer is B, response-based PPS for CRS with screening all residents on that unit. Same case study, same background. The long-term acute care hospital, or LTAC, decide they are going to do a response-based PPS of the whole unit, and they identify 5 more residents who's colonized with CRS. CRS outbreak has been identified at a neighboring facility, which frequently transfers patients to them, so it's a back and forth sharing of residents. Which brings us to question number 2. Which of the following recommendations would the health department likely make next? Would they A, allow the health department to assist with an infection control assessment or an ICAR? B, conduct another response-based PPS in several weeks? C, look for CRS at a future PPS? Or D, all of the above? Anybody brave enough to guess? I've got a D, I've got a couple of Bs. Let's take a look and see. It would be D, all of the above. Okay, same background, case number 1. Another response-based PPS to identify CRS is conducted on the ventilator unit 2 weeks later after improvements in hand hygiene performance were made. Another PPS identifies 2 new residents that are colonized with CRS. Question number 3. What should that facility do next? Do they A, give up? They just can't control this MDRO. B, ghost the health department. C, continue to evaluate and correct the infection control gaps. Or D, blame the facility up the street. That MDRO must be coming from them. And I hope nobody says B, ghost the health department. We wouldn't like that. Any guesses? I see C. Everybody's saying C. And you would be correct. Continue to evaluate and correct the infection control gaps. All right, case study number 2. The infection preventionist at an LTAC was reading a health department alert, like that HON that I showed you earlier, about the sudden increase of CRS in the area. The IP has already begun assessing and improving their current infection control practices, but she wants to do more. Question number 1. Which of the following colonization screening activities could she suggest to her administrator? Would it be a proactive PPS? Or B, a discharge screening? C, admission screening? D, would be both A and C, or E, all of the above. Let's see who's guessing. I have a D. Anybody else? Another D. And the D's are correct. You would definitely want to do a proactive PPS or point prevalence survey. And you would also want to do admission screening. So once you've screened everybody, and then anybody who is new that comes in, then you would just have to screen those people. A little more background on this case study number 3. Oh, I'm sorry. This is a new case study. Background on this patient shows that they are in the medical intensive care unit in an acute care hospital, where the hospital is experiencing a CRS outbreak. 4 patients are included in this. They do 3 rounds of response-based PPSs and continue to find patients with this MDRO. They find critical gaps in their infection control practices, and that was found during the ICAR. So when the ICAR team came in, they did some surveys, and they were able to identify that hand hygiene was only happening half the time, that staff was not routinely using gowns, and that shared patient equipment was not routinely cleaned between patients and disinfected. So let's see what happens next. Question 1. What steps can this facility take to limit transmission to other healthcare facilities when they transfer patients? Would they do A, discharge screening, B, verbally communicate with any facility that accepts patients with that MDRO in transfer, C, continue to work on improving infection control gaps, or D, all of the above? We've got D, another D, and that's correct, all of the above. That communication piece is so very important. I'm almost out of time. I'm so sorry I got to talking, but are there any questions, comments, anything that I can clear up?
All right, thank you, Valerie. We don't have any questions or comments so far, so I'm going to run over a couple of closing items, and then if anybody has any questions, please put them in the chat or the Q&A tool. You can also raise your hand if you'd like to ask your question out loud. While we're waiting, I'd again like to invite everyone to next week's webinar, which will be a replay session of our recent webinar on increasing infection prevention with interactive education, followed by a live Q&A. And that will be next Wednesday at 2 p.m. We also invite you to bring your questions to our live chats every Tuesday and Thursday at noon. One of our quality improvement specialists will be there to answer questions on topics like quality improvement initiatives, infection control, or MDS coding. You can find the links to our live chats and our office hours and our webinars in the newsletter we send out every Friday called the Last Minute Lowdown. And if you'd like to receive that newsletter but don't think you're on the mailing list, you can email me at ccaudil@qualityinsights.org and I will get you on that list. And now I am going to drop my email in the chat along with Valerie's in case somebody would like to copy it down. And it doesn't look like we have, oh wait, there is something in the Q&A. Here we go. So there's a question. It says, could you please clarify cohorting?
So similar to you might have experienced during COVID, if you have 2 people on the same unit and they have roommates, then that would be a situation where you would want to try to get those 2 positive patients together. Ideally, I said several times, private rooms are the best idea, but if that's not possible, then you go to the next step. Does that answer?
All right, thank you, Valerie. I think that answers the question. If the person who asked it has follow-up questions, let us know.
Mm-hmm.
And we'll give this just one more moment, and then I think we can wrap up. They said, yes, that does answer the question. Thank you. All right, I think that is it for questions. So I will go ahead and wrap us up. As Valerie said, I will be sending the slides to everybody here today. I will be sending them a link to the slides using the email that everybody used to register today. Just want to see one more thing in the Q&A. They're saying thank you. Yes, so a link to the recording and a link to the slides will be sent to everybody here probably on Thursday or Friday. And I think that's it. So I'm going to go ahead and wrap us up. Before we sign off, I'd like to ask everyone here to please answer a short evaluation of today's webinar. It is anonymous and will show as a pop-up as soon as the webinar ends. So if you have a couple minutes to fill that out, we would appreciate it. Valerie, I would like to thank you for joining us today and for this great presentation. And I'd like to thank everyone for coming today, and we hope to see you again soon.
Thank you. Have a good evening.